Good afternoon, everybody, and thanks for joining us on this programme today. On behalf of the Health Foundation, I'd like to give a warm welcome to all of you. Today we're going to be talking about how we scale up improvement and collaborative approaches at a larger scale. And joining me are three members of the Emergency Laparotomy Collaborative, Sadie Leek, Dr. Neil Quiney, thank you, and Geeta Agarwal. So today what we want to do is demonstrate the expertise within their programme, and they want to offer you some peer support that you can apply to your own piece back at base. In a minute they're going to introduce themselves, but I'll also say who I am. I'm Nikki Davey, and I've had the privilege of learning about and doing improvement work both at the NHS Institute and with the Institute of Healthcare Improvement. Since then, I've gone on to create the Quality Improvement Clinic, and I continue to work with practitioners from the patient safety collaboratives and the clerks and also clinical trainees in practice. I'm interested in what makes a collaborative work really well and how we tap into the discretionary efforts of frontline staff. And we engage around a shared purpose to move this improvement effort forward. I hope you find parallels and connections in what you hear today, and that you take at least one piece of learning back to base that you can use. As you listen, you can submit your own questions, but if you have your screen extended, then you won't be able to see the question box. So you'll find if you just reduce it down, the question box will be at the bottom and you can just start typing in at any time then. And we'll come on to the questions after they've shared a little bit about their own journey and their learning journey with you. So first of all, I'd like to ask Neil to introduce himself and just tell you a little bit about the background of the collaborative they're involved in.
Okay, I'm Neil Quiney, I'm an anaesthetist from Guildford. Someone accused me of being a surgeon on Friday, but that's not true. So I've been an anaesthetist in Guildford for about 20 years. And I guess as to the preamble to this talk, I've been clinical director of a couple of different departments in the hospital, so anaesthetics, intensive care and the front door. So this project really grew out of a SHINE project, which was 4 hospitals in England, pretty much the same size as Guildford, looking at ways to improve outcomes, basically mortality rate for emergency laparotomy. And in that we used a simple 5 or 6 point care bundle and implemented over a period of 8 months. And we had about a 25% reduction in crude mortality rate. So this project, the Emergency Laparotomy Collaborative, is a scaling up of that project, as it's called. And it's collaboration on many different levels. So we're collaborating with 3 AHSNs, that's Wessex, KSS and the West of England. So they're a group of people I've not met before. Okay. And then there's 29 hospitals within that group who are working with us to share, learn, collaborate to improve outcomes. Okay,
that's great. Thank you very much. We'll come back to a few more questions a bit. Sadie, you are the programme manager, and the way in which you've partnered for this award gives us some really good insights into how you develop that collaborative relationship with so many sites. Can you just tell us a little bit more about that and about your role in that?
Okay, so I'm the programme manager for the Emergency Laparotomy Collaborative, working at the Kent, Surrey, Sussex Academic Health Science Network. I also work with the Kent, Surrey, Sussex Patient Safety Collaborative. So we've partnered with Royal Surrey County Hospital to roll out this emergency laparotomy care bundle, working with the Wessex and West of England AHSNs as well, as Neil has mentioned. We have over 100 anaesthetists, nurses and improvement managers working with us to implement this care bundle. So we meet on a regular basis, we hold certain events working together and interacting in this way.
Okay, and we're going to hear a little bit more about that in a minute too. Geeta, I described here asked you before about what it was that made you want to get involved in this collaborative. Do you just want to say a little bit about your role in this?
Yeah, so I'm just an anaesthetic registrar, but I came to the Royal Surrey as part of my training programme, and the SHINE project had just closed, but it was a really exciting opportunity to try and improve mortality for this sort of group of very high risk patients. So that's what really sort of helped me get involved. Really.
Okay, that's great. When I talked to all of you in the last few weeks learning about this programme, there were 3 things that particularly stood out for me. And so I'm going to ask them to share these things with you. The first was about how you built trust very quickly with all the people that are involved. We've just lost our slide, so I hope that's going to be brought back in a minute. And the second was building a strong core team. And then finally, it was about the use of data and the time to talk. So we're going to explore these things in a little bit more detail now, starting with building trust quickly. And Neil, as the clinical lead for the project, you had a bit of a head start, as you said, through Shine, but you recognised the need to influence people right from the start.
Yeah.
Do you want to talk a little bit about that now?
So I was thinking about your question over the weekend, and I think the influencing part of my career started when I became a clinical director.
Yeah.
So it's quite. So when you take that step up to running a department or being involved in running a department, you're influencing people. It's relatively easy because you're all from the same background, you're all anaesthetists, and you're all gone through the same professional training, you're all doing the same thing. So you speak the common language. In terms of the Shine project we did, which was the 4 hospitals around England, I didn't know the leads for those trusts originally, but again they came from the same professional backgrounds, and the influence in them was relatively easy because we spoke the same language. In this project it's different because there's a lot of people I don't know and they come from different professional backgrounds. So I guess some of the skills which I've learned earlier in terms of trying to influence what they do and what they think and what they say to me has been transferred and grown over a period of quite a few years, I guess. So when we started this project, I sort of thought, well, it's a big project, what are we going to do? So I guess the first thing when we were setting up was the setup phase for 6 months was trying to get consensus across that sort of disparate group of people with different agendas, different backgrounds, different professional training. So when we started meeting, getting that consensus was important. Now, we were lucky because we had a care bundle which we'd used quite successfully before, so that was sort of almost taken, but there's still quite a lot of discussion about some of the specific points of that care bundle. So over time, people felt they could speak their minds in our meetings, they could contribute, they got a bit of buy-in to it, although we didn't just say, here it is, take it or leave it. I think people felt they owned a bit of it. So ownership was built over that period of 6 months. And then also try and understand a little bit about, and I think people making sure they could speak up in meetings and contribute, but I think also try and recognise the other professional groups, so working with people like Sadie and her predecessor, they're from a QI background with the HSN and they have different masters, so to speak, to answer to. So trying to make sure that they were getting something out of the project as well was important. So, you know, at initially for the 6 month setup, it was very much getting people to buy into this idea we had. Taking it further out, so our first big launch in September so that's mostly to a group of fellow professionals, so anaesthetists, surgeons, intensivists, some chief executives. Again, it was trying to speak the same language to them, express what we'd done before and get them to buy into it. And that was, I think, relatively easy because we had good evidence and good data to convince them.
Okay, that's really helpful, thank you. And I know you mentioned that was in the first 6 month phase. I just wanted to ask you, Sadie, to reflect on this next slide, which is about, as you're going through these projects, people come, people leave, and then more people come on board. And I know you didn't come in right from the start. You have a really useful diagram here, I think, which begins to explore and describe the structure. Could you just talk us through a little bit through this one for us?
Okay, I hope people can see this. Our aspiration is for the hospital teams to take the improvement work and to run with it. And we see our role very much as one to support and enable dialogue and that interaction. So each AHSN supports it's local trusts and hospitals. Their responsibility and their role is to build those relationships, to offer support by responding to queries, issues and so on, and organise local opportunities for collaboration as well. And on the next slide, the 3 AHSNs actually work together as a virtual team, but we come together every 6 weeks or so, and we meet, we feed back to each other, we discuss our plans and agree our actions for taking the programme forward. And we find that this feedback really helps. It helps us to steer the programme, and the regular feedback makes us more agile and responsive to people's needs.
Okay, that's really helpful. I know we're going to come back and talk a bit more about that in a moment as well. So I just wanted to ask you, Geeta, the second strength I noted is that you've built some really strong core team, or maybe we'll call it a virtual team, at the centre. But you came to this programme without portfolio, really, and you've engaged, and now you're actually a very key and critical player in this. Would you like to just give us a flavour about how you came into this place and established your own roles and responsibilities, and also began to understand that of others?
Yeah. By without portfolio, I'm assuming that you mean that I just wasn't on the original bid side of things. It's a really good question. In terms of clarity, I don't think there was much in the way of clarity of my role to begin with, and probably there still isn't. I work at the base hospital, the Royal Surrey, and I work with Neil, but essentially I was just starting to do work that Sadie's predecessor was quite busy to do, but also there wasn't really a role for anyone to do those things, so things like the posters and the website and all the visual side of things. I then started to help set up with Sadie and Neil the agendas for the meetings, and then continued to present some of the other work that I was doing, and have now become the principal investigator for a sub-project within the collaborative. So so there is some clarity with my role with the sub-project, but essentially I try and work with the hospitals directly, as well as the AHSNs, just according to that diagram, and then across the ELC sort of central team as well. So it's just trying to find, I essentially am that link between everyone, I think.
So I see that as a really important bit of glue, actually. So you said, well, you haven't got a role, but actually you have many roles, and they're all quite critical to this project. Not least, I think, which is also working particularly with Neil, operationalising the kind of great ideas and insights that you have about how that will play out in practice and how you communicate that. We've got on this slide here just a diagram which I wanted to share with the audience, which I think is a really nice summary of the journey that you're hoping to take. And that's also reflected in the second slide, and a guide that you have, which I think is extremely accessible to people to tell them what they're actually getting involved with in the collaborative. Can you just say a bit about at what point you actually decided this was important, and at what point you started sharing it and shaping it?
Well, I think it was probably after one of our sort of central collaborative meetings with all the AHSN leads
during the setup phase.
During the setup phase, so it became apparent that actually us, as well as the AHSNs, didn't really know what the journey was going to be. So trying to work that out all together, and then putting it into an email, and the emails getting lost, it was all quite difficult to do. So I just thought we'd make a quick diagram of it, and then it got sent out. It was revised as people sort of changed their ideas and things, but it was all done in the setup phase. Really. I
mean, certainly as somebody coming fresh to this, I found this really helpful.
Yeah.
So I thought, actually, I can engage with that. Very, very nicely.
Yeah, we try to keep it as simple as possible, and that's been sent out to all the hospitals and the clinical leads and things, so they understand where we're going with it, as well as the teams itself, the central team and the peripheral team.
So when they're working with QI people from their own hospital as well, who don't actually understand this particular clinical piece, that's a very good aid. So you can see here on the next slide, this is just one page out of a really neat guidance that they have. So if you have a need to communicate and think you're missing a trick, maybe this is something you want to look at too. Okay, so I'd also want to come back now to Neil, because I want to talk about data. So for quality improvement, data is what I consider to be the major game changer, really. And that certainly Neil described that. It's our sort of highlight in the improvement work that we do. Neil, I'd like you just to tell me a bit about your early experience with data and what you think you've done that has begun to make a difference for your partners out in the collaboratives.
Okay, so I really got interested in emergency laparotomy about 4 or 5 years ago when there was a publication. The Royal Surrey took part in an audit looking at outcomes, and we submitted data for 3 months, and lo and behold, we found our mortality was 21%. Now, that was really quite a sort of scales off the eyes moment for me, because we were pretty proud of our elective outcomes in Guildford, and that was really just quite extraordinary. And it became obvious that someone like me in my position, having been involved in running the department, should take some steps to do something about it. So, and that data allowed me to go around the hospital at that stage saying, we have got to do something about this. That to the surgeons, to the radiologists, to the A&E doctors. So it's a really powerful number to go to and say, we've got a 1 in 5 chance of dying for these people. And it's a very persuasive argument. So that was the initial buy-in for me and for many other clinicians around our hospital. And when we ran the SHINE project, we used very similar types of methodology. So each hospital knew their outcomes. They knew we had this pathway by that stage. They knew what the performance was, how many people were going to intensive care, how many people were getting a consultant surgeon operate on them, how many people were getting antibiotics before surgery. And it wasn't very pretty sometimes, but there's been a general understanding about poor outcomes from laparotomy since 1985 or 6 when I started anaesthetics. But it's when you know your own data, it becomes really powerful. And that again, for those the Elkwick Shine hospitals, was powerful for them to influence people and change. For this project, so the collaborative we're running now, we're quite lucky because in that time, there's been a national database set up, which is the NELA database, National Emergency Laparotomy Audit, which is a compulsory or mandatory database for all trusts for all patients having emergency laparotomy. But until relatively recently, people have fed data into it, this black box, and never got anything out of it. So, switch off time or what. So we put together a macro for them and started showing people their run charts and their performance. And the run chart was, what was important was, roughly what percentage of people were getting X, Y, or Z. And I remember, I think it was at the Wessex meeting, it was just remarkable. People were looking at this for the first time and said, that's us, is it? And it's like, switch on the TV for the first time. That's a television. Yeah, that's what your performance is like. And again, I think I'd hope quite a few of the teams are starting to use those on a regular basis to inform the discussions and change people's behaviour, really. And then the thing which is, I think, going to come out this week is which we're going to have a dashboard for all the trust performance. So people can then start getting competitive with one another because we like that. And so I think that's going to be a reinvigorating step for many of the trusts. They've looked at their own data and they can compare themselves to their neighbours. And I know one of the hospitals in the west of England has got a problem with getting some consultant buy-in. But when they can show their consultants they're the lowest performing of the 29 hospitals, they'll start changing. So I think it's going to be a really powerful tool for some of the hospitals who are struggling to get a bit of buy-in and change behaviours.
Okay, and so it's quite interesting in terms of use of language there, isn't it? I've worked with data and feeding data back to clinicians for a very long time, and it's true that when they feel that that's been brought to them for their reasons from other clinicians, that they have greater interest. So I think I'll reframe it more in terms of their learning and the opportunity to really perhaps not be so disappointed about where they are, but to go look and find out what they can learn from others. And because you're going to be able to see specifically on this data who's performing, and probably nobody is performing perfectly on all 6, but some people will be excelling on more or one or two of those, and they can go and have a look and have that conversation.
Well, we've found that in our feedback from both the local and the sort of more regional meetings, that the thing that clinicians like is time to talk about their performance and their data, because they don't get a chance to do that back at base. and we're trying to form these sort of groups of learning within each HSN, so they can pick up the phone or call a mate or send an email, say, how did you fix that, because I could see you doing it well. So that learning is going to be very much a part of the sort of middle and the latter part of this collaborative, learning from each other.
Yeah.
And then hopefully after the sort of summer break, we'll switch people around so that people from KSS can learn from West of England and vice versa. So we've formed these learning groups, and we'll get people to share across a wider geographical region then.
Okay, I mean, that's really helpful. And Sadie, I'd just like to come back to the picture that you've put together, which just describes the relationships here, and ask you to just tell us a little bit about how this structure has helped you do that. Neil spoke about, we just did a macro. So one of the things I'd like to share with everybody, I mean, that might be easy for you.
Sorry.
But
I didn't do it.
But one of the things which a collaborative can bring is it can bring a resource that is not accessible to individual practices, individual hospitals, or even individual AHSNs, and it can allow an opportunity to make that viable and feasible for everybody else to share in and have access to. Mm-hmm. So you also mentioned time to talk. So I just want you to tell us a little bit more about that, Sadie, in terms of your role and the kinds of conversations that you've had, why that's important, how it happens in the many different ways that it does.
Okay. Time to talk, I think, is so important because every time we meet, every time we talk, we're actually building our relationships with each other. Each time we meet, I think we're learning to talk more openly, which helps us to build a consensus more quickly, to reach a decision and to act accordingly, and to agree our next actions. And the trusts and hospital staff have also said to us that they really value those opportunities to get together at the collaborative events, to talk to each other and actually to then plan their own work and how they can improve and implement the care bundle and move forward. So I think using data as a way of driving the conversation, I think is very important. But last week at the IHI conference in Sweden, Gary Kaplan, CEO of Virginia Mason Medical Center, was talking about their learning, the lessons learned from their improvement work. And one of the things that he said which stuck in my mind was about the use of language and how we shouldn't use words like rollout and buy-in with clinicians. And I think when we talk and when we plan our collaborative events, we are very conscious of how we are passing messages on and the language we're using. So statistical process control might turn a lot of people off, and I think we just need to be very conscious of that.
Yes.
Yeah.
And what I liked about your diagram is that you've shown the team in the middle. I know you struggle with whether you call it a regional team or a core team, whatever, but you've actually, in your diagram, got it with dotted lines around the outside, which gives a sense of its lack of permanency, but also the fact that it's empowering people. Yes. And I know that the other thing you talked to me about is actually just getting on the phone and having conversations, which, having had a face-to-face meeting, is very easy, but actually probably is quite important for ensuring that you reduce misunderstandings, but also, like you say, to get everybody able to feel that it can contribute. We perhaps don't always make enough time for that normally. We sort of send an email and hope.
Yes, and actually, if a decision needs to be made about something, it's so much easier to just pick up the phone and talk to somebody. Are we allowed to talk about the intentional error of that slide?
Absolutely, please do.
So we were talking about this last week in Gothenburg, and so the whole idea about this project actually is the trusts are on the top, supported by the AHSNs, and then actually the ELC team, as it's called on that slide, at the bottom, because at the end of this project they will disappear. And we hope the trusts will be able to stand on their own 2 feet and run their own collaborative projects on whatever subject they want in the future. So this top down is the wrong way up. It should be from bottom up. We're supporting them, and we will take that support out eventually at the end of this project, to allow them to just run their own projects going forward.
Okay, and I also want to come in on that piece as well, because that is one of, we'll probably come back to it again at the end, but that's one of the things which is really important with a collaborative, is it gives you an opportunity to do things that people cannot do by themselves. Yeah. And so that central resource, whatever you call it, virtual resource, that collective resource, which in this instance actually is both, it's shared at the central level that's showed in the ELC team at the top, but it's also got a distributed leadership piece around each AHSN, and then further down that to each of the teams in the hospitals, which I think is really powerful. So on that note, I think we're going to ask if you'd like to bring some questions in now from the audience. I know that you've all got different collaboratives. I know that this one's got many partners. Some of you are just in a partner of 2 sites. But one of the questions we've had in already is asking you about if you can recommend any social media or virtual mechanisms for ongoing collaboration and engagement, particularly with those staff in the front line. So can you say a little bit about that as well?
So the social media that we've used is Twitter, and we've got the Emergency Laparotomy Collaborative handle. We've also used Facebook, and then we've gone into webinars. So rather than trying to meet every single clinical lead, because we're quite a big collaborative, it actually is quite nice for leads and teams peripherally to just log in and again share learning. All virtually. So we set up a template for some slides, they filled it in, and then they just talked on the phone and shared those slides and the learning. And what we found is that those networks that Neil was talking about are already forming. There's already sort of well, supper clubs or drinks clubs going on with the Laparotomy Collaborative. We're not invited, but it is all happening. So. Well, I'm invited, but yeah. So it's really we've used the mainstream things like Twitter and Facebook, but webinars are a great resource to use.
It helps with the connection, doesn't it?
Yeah.
Can I just add to that?
Yes.
You mentioned connection. I think it's quite important. I've never worked on a program actually that has an identity like this and the branding, and I wonder if there's something in the hospitals and the teams that are working with us, if there's that sense of identity and connection to something that's actually bigger than them. That I certainly feel this program is bigger than us, it's bigger than them, and actually.
To know what the teams on the ground think about that, because we've worked on this a lot and we feel that strong a bit. I'd be interested to know, but I have got them in the back of my mind, so that I've got a few plans about how to get that sort of ownership on a bigger scale outside their own trusts to happen. But that's been mentioned before. That
the other thing that I've noticed about it being a collaborative, I feel that there's a deep but unspoken appreciation that actually we all depend on each other to succeed.
Yeah. So that's really come to collectively together. So I think that's interesting for those of you who perhaps, don't have that feel at the moment. I think that's something that's quite important to look and see how you can, what you can bring into the equation that's going to actually begin to seal that for you. Or one of the other questions that's come in, which is what other help exists or any advice you have to help sites that are far away from each other and who are struggling to engage. So it's quite interesting, this concept of far away from each other, because actually you go from Kent, I think I'm right in saying, right the way over to the southwest. So actually that's a huge geographical area, and not all of the people involved will have met face to face, although lots have. But do you think it's any different when there is no opportunity to actually meet, or are there particular people who need to meet to really make it work? Is there a place you need to start in those relationships?
I think for us the local events help the local teams to meet, and then the larger cross AHSN collaboratives helps everybody to come together. I think there are different ways in which meeting up can be achieved, no matter what the distance.
Yeah. And
I think it's important to keep people engaged with ongoing messages. So the webinar is a good example. The newsletter you've put a couple out of, and the various social media tweets or whatever come out. But I think what's really interesting at the learning events, when people are actually allowed to talk, the groups are starting to perform quite strongly now, and you sort of recognise members of the different teams, and they're quite willing to talk to each other pretty openly about what they've found difficult, who the problems are, where the problems are. So I think that's becoming quite strong. I think you need, if you're far away, you need to keep people's interest going with some of the social media type things, but I think actually ultimately the face-to-face is pretty powerful as well.
And I'd just like to add to that. So if there's a hospital that is quite far away, or they're a bit behind with the care bundle and things, we have quite an open door policy, so they contact me or Sadie or Neil directly, and then we're quite prepared to just go down and give them the talk and see where their issues are, and then really help them come along, rather than just letting them carry on and trying to find their own way. We're very much sort of helping them up.
Pretty open access.
Yeah.
And I think there's something in that to understand why they're struggling to engage.
Yeah.
That it might not just be the physical distance, that there might be something else underlying that you know, would be worth understanding and helping.
I don't think the physical distance has been an issue for us at
No,
all.
not at all.
There's been other issues on the whole.
Yeah.
So you talked, Neil, about changing behaviours through the collaborative, and you highlighted the data competition as one way you can get to that.
That's what I'm hoping, yeah.
Yeah. So how else do you think the collaborative changed behaviours? What other things have you seen or felt when you've been involved? Particularly if you think back to people who weren't very engaged, who've now come on board.
Well, I think right at the beginning of the project, when we first had our big meeting in Reading in September last year, I think just getting all the information together in one place, you know, so there's some of the evidence which is out there people may not be familiar with, some of the things which we had found in our original Out Quick Shine project, which helped, and sort of transferring that to, or letting people know how that worked. So there's definitely just the basic science information or the evidence for the project.
I think that there's data competition. As Neil mentioned, there is the national audit now, so people are putting in data, but they're not really getting. I mean, they've started getting something back, but it's not huge amounts. Whereas they do want to understand their data a bit more, and then it's just playing on the trust itself. So. Going in there and saying, well, you know, this is how you're doing, and surgeons just being quite competitive with each other, as well as the trust, as well as nationally. It's very powerful, that competition. And
I think also that the just looking at the question a bit more, that I think when the time to talk period, I think there's probably more change in behaviour happening there than we probably appreciate, because there's, you know, people say things or make comments about how they've overcome a problem, what happens in their hospital, and that's standard, isn't it? Isn't it in your hospital? And I think all the people don't say, oh, they sort of go away quietly and say, I'm going to fix that. Yeah. And I think so. It's difficult to measure it sometimes, but I think that sharing of information, that learning community, is really important to changing what people do and realising actually they may not be as ordinary or as good as they think.
Yes.
And in fact they're sometimes less than ordinary.
Yeah, no one wants to really admit that they're not. They might think that they're doing something well or poorly, but they don't want to admit it. But when they see that other hospitals are doing things exactly the same way, but there's a way of doing it better possibly, then they don't feel quite so embarrassed about doing things badly. So they're quite open about talking about it. Yeah. So
I mean, also the other thing I'm quite interested and curious about is the way sometimes sites think that, like, you know, they know how to do it, but actually the opportunity for ideas and invention, if you like, or innovation, when you've got so many people, is much greater. So have you had a sense of, for yourselves, have you had things revealed to you that surprised you, that you've sort of said, I'll still that, you know, we say still with pride in quality improvement world. Have you found things that you said, actually, yes, I'll have a little bit of that too, even though you started it off?
I think I've lost count of all the stuff that I've stolen and passed off as my own. I think that we're constantly looking at other collaboratives and other joint ventures, as well as sort of single trust type measures, and then saying, well, actually that's worked really well, or maybe we can adapt it slightly to work at it better for us. So
one other thing could I just mention about, so one of the things that's actually come up quite often.
Can I just ask first? Sorry, you can hold on to that. If you haven't put any questions in yet, could you just reduce your screen and add questions, because this is your opportunity to hear from them, the panel with all their expertise, and they may not have the answer, but they might generate an idea that takes you to an answer for yourselves.
So what I was saying is that quite a few people come up to me actually think about it and saying at the time to talk type events, we want something from you, this collaborative, to take back to our hospital to change behaviour. Now they know by themselves, if they say, I think, it's not going to happen. But if they have information from this collaborative, this bigger group, that say all the other hospitals do it like this, or what about trying this, or the evidence is that. So we actually bring back together sort of whole host of resources for them to take back to their own hospital, and then they can sort of, with their run charts, they can work out what their issues are, and they can choose and pick whatever from that sort of medley of things they've got from us. So I guess that's probably one of the ways people change behaviour. We never see that, of course, because that happens back in their own hospitals. Yeah. We might see it on the run charts later.
Yes.
But I think there's one or two people that's really come through strongly, actually. They've said, we need your collaborative to get the information, the data, to take back to change behaviour.
Yeah.
Could I just add?
Yes.
There's a sepsis element to the care bundle.
Yeah.
And actually one of the things that I've noticed is, because of this improvement work, tying in with sepsis improvement work, which might be happening elsewhere in the hospital, I think it might encourage people to actually work together a bit more in the hospitals to actually find out how their work is impacting on other people's work, and vice versa.
And I also just wanted to explore with you, and related to that really, is about the involvement of the non-anaesthetists or non-surgeons, so the other professional groups, and also the QI specialists, whom hopefully in these teams they've been encouraged to go out and find in their organisations and make contact with and draw them in. I think you've started to having some more people with a QI background coming in through those doors.
I think there's a few, but really we're trying to establish a QI syllabus and give them baseline QI knowledge. So really we are hoping for people who don't have QI knowledge, so we can actually give them the QI knowledge for them to then, once we are gone, they can continue doing collaborative work and other improvement work in their hospital for years to come. Yeah. So
it's a bit variable how many sort of QI people are hanging around hospitals these days. They seem to be being chopped pretty rapidly.
Well, you have to be smart to find them.
Yeah. What we did do at the beginning of the collaborative, talking about working on the professional groups, and I call chief executives and medical directors a different group. So we actually approached them first of all when we sent out the invitations, rather than just send it to a surgeon or a anaesthetist. And I think getting them aware of the project and getting that sort of buy-in was quite important. Certainly there's been 2 or 3 hospitals definitely where there's some issues or questions from the sort of frontline staff about we haven't got time, we haven't got resources, and actually getting the chief executive involved, knowing about it and sending off the emails has helped actually quite a lot. Yeah. And I'd hope on the flip side to that is that the people running the project, if they want to make changes in the way the hospital runs, which they don't feel they can do themselves, they've got a place to go to say we want to change the way you run CT scan or the theatre orders or whatever it is. So at least they've got a friend in a higher place to maybe help them resolve those issues, which actually often, when you look back at it, it's a letter that needs to be written by the chief executive. It's easy peasy. But you just need the right person to write it.
Absolutely, and we know that that's really critical in terms of will ideas and execution. Having a sponsor who will just open doors or unblock things is really important. Yeah. So I have another question for you. This is the tough one actually, which is, what have you personally found the hardest as a clinical lead of the project?
Is that me or her?
Well,
you're the
clinical lead. I think that's yours.
Working with me.
Yeah, now you mention it. I think, so it's been a lot bigger project than I thought. It has taken a lot of my time. Well, it's a 24/7 project, isn't it? You think about it all the time, and even when you're in theatre. I think probably the hardest thing, the things I've enjoyed are working with clinicians and seeing them use new techniques and ideas. I think, I suspect actually the thing I've learned most is working with other professional groups, and they've got different agendas, they come from different backgrounds and they speak a different language. And trying to, well, I'm not pointing fingers.
No, back to language.
Yeah, it is. But I started off with language originally. It's relatively easy to try and convince a group of 15 anaesthetists to do something. But actually when you're talking with people from a different background, and so making sure they were engaged at the outset and not getting them switched off, making sure they wanted to contribute and felt they could contribute. I'm not sure I've done it very well, but because we've lost quite a few of our QI people. No, through other reasons. But so I think that's probably been the biggest challenge and most interesting part of the project for me, to see how you work with those groups of people. And there's been lots of other things. I've learned about infographics, and
I've taught you a lot.
you taught me a lot, and run chart makers and all sorts of things. So there's been lots of really interesting things, and doing this sort of thing is interesting. I haven't been in a TV studios and stuff, and I met you. But I think that's probably been the biggest challenge, is working with people who I don't naturally work with, QI people, HSM people who have come from a different background.
Yeah.
And I found that originally actually with the Shine project, that it's quite easy to convince your colleagues who you work with day in, day out, including the surgeons, to change what they do. But there's like an onion skin. You go to the next level, which is, say, the radiologists, who I see maybe once a week, but you've got to convince them to change. And then the next layer is the physicians and maybe the A&E department doctors, who you might see once a month. And so you've got to somehow get your story across, that it's worth changing what they're doing for the reasons you give. And that's, again, data is a really powerful and key tool to be able to convince them. Rather than saying, I think it's a good idea, there's lots of ideas, but if you've got some evidence, even if it's just one scrap, your mortality rate's 21%, it's really powerful.
Yeah.
Yeah.
Yeah. And Geeta, what about you? What's
So the question is what have I personally found the hardest? It's, I think, as Neil said, it's a 24/7 project.
Yeah.
And I'm also an anaesthetic registrar, so I'm also doing lists just like Neil, but it does take a lot of time to work things out, and I'm constantly thinking about it. I'm sure my husband will agree. Yeah, it's 24/7, but it's hard to, that's probably the hardest thing. And as Neil said, it's been an interesting learning curve, working with the QI specialists, working with managers who I've never been exposed to as an anaesthetic registrar. But at the same time, it's also been very enjoyable, and the skills that I think we all learn with that is something that is very transferable to other things.
I'll come back and ask the same question to you in a minute, Sadie, but one of the things I just wanted to draw out from that is with co-production with collaboratives, one of the things you are able to do is to tap into that discretionary effort of staff. So when you light people's fire with a great diagram which shows them the journey, when you share data, when you start telling the stories, actually people who could have chosen not to be involved, which actually that could be the case for you, Geeta, it wasn't in your job description, you could have said, actually I've got other things to do in my life. Actually you get people fired up and they see an opportunity to make a difference. And I think this is the thing that's extremely powerful with collaboratives and made possible because of this relationship between local and some central kind of capacity. And so I'm going to ask you that question as well. What have you found the hardest?
The hardest, actually, I don't actually find this a very hard program. The reason is because the clinical outcomes and the measures are very clear, and I think that clarity is so important because it's what drives people. If you're sort of fumbling your way in the dark, trying to just improve here and there, and you're not really looking at or measuring what you're improving, then I think that can be quite difficult. So in terms of hardness, I think no, but it's very enjoyable, I must say.
Yeah. and I've seen their data, so the dashboard that they put together and their ability to show that and share it with everybody is really, really good. So the other questions I've got, you brought up the question about what happens when it comes towards the end, and what do you think will happen going forward? How do you think, what's your sort of vision of what you think is going to happen, and what are your plans for the sustain and spread of this kind of piece of work?
So, right from the outset of the project, we've had quite a few either individual hospitals or groups of hospitals trying to join the project, but we had stretched our funding anyway, and we probably thought enough is enough. So we sort of turned a few people down. So there's quite a lot of appetite for this specific project around the UK, and I think overseas as well, because now quite a lot more evidence coming out that this type of approach is pretty a sensible way of approaching this problem, which seems to be a multinational problem, same as in the USA and Denmark. So hopefully the project will we'll potentially work with other groups, other colleges or government organisations maybe to take up some of the ideas that we've put together here. So that's one thing. I think the other thing I'd like to try and support, despite the project coming to an end, is the sort of QI knowledge for clinicians, because I came to this knowing nothing about QI. I went on a course in Boston for a week, which was amazing, but I sort of read and learnt about it myself through my own enthusiasm. And I think having a resource for people to go to when they want to talk QI for the next projects, the next problems when they're running departments in their own hospitals, I think, and if they can start developing some of the key elements of that language, so they can communicate with the QI people or know where to look on the internet, I think that's really useful, because I just sort of learnt it as I went along. I think it'd be useful just to have a bit more easy access. So if we can support something like that, that'd be helpful, I think.
Yeah.
So that's the legacy, I guess, part of the project.
It is. And I know I said earlier that about finding QI people, actually I do see a bit of a sea change in the numbers of people who come through who have a bit of the language now. It's still not always easy to find them, but I'd encourage everybody to keep your eyes open and keep looking out for those people who've already got a little bit of a step up, particularly trainees coming through in some of the professions now.
I think that's the key, is that the junior doctors seem to get quite forgotten, but actually it's all becoming part of their curriculum. They are the ones who will then continue for the next 30 years.
In terms of, obviously from the HSN's perspective, I don't know if you've had any discussions yet about how that's going to feel and how the HSN's, what their ambitions are for taking this forward. Is that a conversation that's beginning now, or is it a little bit premature still?
I'd say it's premature. I think if we could look at how we're performing, and how we're performing, then we can have those conversations. But something I did find interesting was when I was talking to a consultant anaesthetist from Plymouth the other day. He said, "Emergency laparotomy collaborative, yes, I've heard of that." It's really interesting, and I wonder how it will have its own momentum as people see what we've achieved, and then will want to do that themselves.
They'll need some support, and the stuff on the website, so the run chart maker and some of the discussions we've had our collaborative meetings, but it's somehow we need to, if the project goes forward, replicate that on a bigger scale. It's something I've started thinking a bit about, the end of the project, how it works, but I've not really got strong ideas. But
I mean, one of the things we know about improvement work is that the context is really important, and that's what I call the adapt and adopt piece, that all the other people that come on this journey, unless they have a good QI sort of ethos within their organisation, they will need support from somewhere to get that piece, because in the same way that the people you met up with wanted to challenge and understand and test the bundle that you had, and does it have to be quite like that, people do need to have an opportunity to go through that type of thing, to adopt something themselves and to fit it for their own context and their own setting. It'd
be also nice to, I think what's different maybe about this and some of the other projects, which are, so this is sort of set up by clinicians and run by clinicians and advocated and owned by them, and what I'd like to do is try and continue that, because I think it allows buy-in a lot better, rather than some blank government organisation saying you will do this, which is a sort of instant turn-off. So I think if we can continue that clinical involvement, ownership would be really useful. Yeah,
okay. That's really helpful, so thank you very much. I just wanted to read out a couple of things about a collaborative and co-production deal, really. If you're, I know that most of you have probably got this fixed within your collaborative, but I think the appreciation of these two parts, the national or the regional or the central team, whoever made the bid, with their other partner, is really critical. So on a national or whatever the collective way, you have the opportunity, which you've heard about today, which is about collating the evidence base and bringing that to the other people in the team. You've also got this coordination role that's going on, and you create the network opportunity, which you've done, I think, and demonstrated so well. And some of that will continue as sort of breadcrumbs and trails that will carry on for many people's career, I think. The particular thing that I think that central role brings is this analysis and sharing of collective data, which I see that time and time again, that when you've got a good collaborative, that is a real key that those people can do. And I know from the conversation we've had that your other partners and your clinical leads in each AHSN have actually helped and, you know, helped you decide. It's not about you deciding it, it's been a collective decision. So I think that's critical. And you've been able to have the capacity to design things like the website and stuff, which individuals don't have. But at the same time, same token, at the local area teams, you've had this opportunity to provide the expertise and energy so that it's not just you carrying on, they're feeding that and giving you something to work with. They contribute to the design, and they bring these extra ideas which you wouldn't have had. They've got a commitment to testing and measurement, most importantly, and also they are helping that adaptation and adoption spread. So I think that's fantastic. So I don't know if there are any other questions. I think for me, as I said, just going back to what I've seen here, those three things which I started on at the beginning really, which was about the building the trust, having a strong team, strong core team, and this use of data and the time to talk. So when I hear these guys talking about how they're planning their next meeting, how they're getting inputs from the people in each of these local teams that you can see in this picture, it's really quite powerful, and I definitely get a feel for this being a two-way process, that it's a constant dialogue and feedback. And I think that's the sort of shared and distributed leadership that's in action that we see here. So I don't think we've got any more questions coming on, so I'm going to wrap up now, I think, with that. I just want to remind you that you'll be able to listen to this webinar again, and actually really encourage you to share it with the people who haven't been able to come on today, because actually they might also find things in it which they can run with without your help, and that's another win, isn't it? And
I was just mentioning about the website, because I think lots of the resources are
Yeah.
on there, and people can look at that as free
yes.
access.
And it's emergencylaparotomycollaborative.co.uk.
There's
I sound like quite a saleswoman.
There's quite a lot on there, I think, in terms of...
There's lots of interesting papers that the Care Bundle was based on, as well as QI, videos, papers, etc.
But lots of those posters and...
PDFs of the posters, so you can print them off.
They'll want them on their own subject, won't they?
There,
They will want it on their own subject.
Yeah, so people should say what they want
But
of it.
you can see what's been happening there.
Yeah.
So I think that's really fantastic. I'd like to thank you for sharing what you've learned, and I know that you'll have opportunities through the support the Frontline give you and the Health Foundation for finding out more and making connections and picking up on any piece that's floated your boat today and that you feel you can go and run with. So thank you very much for joining us today.